Good afternoon, everyone, and good morning to those on the West Coast. Welcome to the Apt Associates Social Determinants of Health Thought Leadership Series. We're happy to have all of you here today for the presentation on the impact of social determinants of health in ending the HIV epidemic. I'm pleased to introduce my dear colleague, Harold Phillips, who is the director of the White House Office of National AIDS Policy. Harold has been living with HIV since 2005 and has worked in the HIV field for over 20 years in both the federal government and community-based agencies. In his current role, Harold is tasked with coordinating government efforts to reduce the number of HIV infections across the United States, overseeing the implementation of the National HIV/AIDS Strategy, and guiding the administration's HIV/AIDS policies across federal agencies. Today, Harold will discuss how the social determinants of health contribute to health disparities and the ways in which programs, practices, and policies affect communities of color and other populations experiencing HIV disparities. He'll also talk about the efforts of the government and private sector partners to address social determinants of health inequities and ultimately end the HIV epidemic. Harold, I'm going to turn it over to you now to share your knowledge and your wisdom with us. Thank you.
Thank you, Jane. And good morning, good afternoon, and even good evening to those who might be overseas. Happy to be with you, and thank you to Jane and the team at APT for pulling all this together. So I am going to share a bit with you about what we have been up to in the Office of National AIDS Policy, which President Biden, in fulfillment of his campaign promise, reignited that office as part of the White House team and as part of the Domestic Policy Council. Next slide. And so I'm going to spend a little bit of time just sort of level setting about HIV in the United States today. Many people say I haven't heard a lot about HIV, or is that still a thing? And I assure you that it is. And I'm going to run through just a couple of data slides to help you understand the context and why HIV is still impacting primarily communities of color and gay and bisexual men in particular. So let's go to the next slide. So currently in the United States, 1.2 million people living with HIV. Of those, 13% have not been diagnosed. And I'll talk about why that's significant and important as well. Of those that are in the United States living with HIV, only 57% are virally suppressed. And this is despite the fact that we have miraculous treatments that are available that were unimaginable 30, 40 years ago that can help people living with HIV live what we call a normal lifespan to their 80s and 90s. The importance of viral treatment is that it helps them live longer, but also we now know scientifically and medically that once someone achieves and maintains viral suppression, meaning they continue to take their HIV medication, they cannot pass HIV on to their sexual partners. So treatment becomes a very important prevention tool in this work as well. In the United States, we have approximately about 34,800 new HIV infections annually. And this has sort of been consistent up until about 2019. Thinking about this over a 10-year span without doing something innovative, creative, also involving the White House around this effort, and this being a national priority, we'd have another 400,000 Americans living with HIV by the year 2030. Next slide. So I talked about where we are in 2019 at 34,800. And this slide that I'd like to share with folks gives you a little bit of hope and progress based on our progress. So from 2015 to 2019 is what sort of the dots show you there on the line graph, and shows you where we are at that 34,800. And then we've had this slight decrease of about 8% after a period of general stability. To the far right on that slide, the 3,000 or less new infections is our target. where we have to get to as a country in order to reach what epidemiologists call epidemic control. So this would be a 90% reduction from where we started in 2015. And that's our overall goal as part of the national strategy, to get to epidemic control by having new HIV diagnosis in the United States at 3,000 or less on an annual basis. So a lot of work to be done. But again, this is showing you where we were in 2015 and where we are in 2019. Next slide. This slide is really important and helps establish the framework for some of the discussions about the impact of social determinants of health. And this is the same time period as the last slide, from 2015 to 2019. And remember, I said there was sort of an 8% reduction. So I'm going to show you exactly where that is. So our first group, if we start with me on the left side of this slide here, our first set of bars shows African-American gay and bisexual men, again, for the years 2015 to 2019. That sort of turquoise solid color there is 2019. The dotted green is 2015. So you can see there's not a lot of progress there among African-American gay and bisexual men. If you continue to move to the left, our next set of bars is Latino gay and bisexual men. Again, not a significant decrease at all. Our third set of bars, which is white gay and bisexual men, this is where we're seeing the most progress. So remember that 8% overall national reduction, but breaking it down by race, ethnicity, and gender identity, as well as sexual orientation, you begin to see a different picture. Let's continue on with this slide, and you'll see go back, there we go, not yet. So our fourth set of bars here, so from the left, 1, 2, 3, 4, that's African-American heterosexual women. And again, you see a decrease of only about 400 individuals. So again, not a lot of progress. And I also like to point out this next set of bars, people who inject drugs. Of all of our groups, this group is going in the wrong direction as well as white heterosexual women, which is our last set of bars there. Some of this is what we are seeing is due to the opioid epidemic and more injection drug use in our country as well. So great concern. This really breaks down that 8% and sets us up for our discussion about social determinants of health. Next slide. Thanks. So similar, I want to include this data here among American Indians, Alaska Natives. And again, this also includes some preliminary data. So we have not connected the line to the final dot there as well. But as you can see, they're also experiencing some increases in HIV diagnosis, and they're of great concern as well. And we'll talk about some of the issues and factors that are driving rates among tribal and Native communities as well. Next slide. A very different way of looking at it, but only the year 2019. And this is significant also because yesterday was National Black HIV/AIDS Awareness Day, where we highlighted the disproportionate impact of HIV among the African American community. And one of the reasons I love this donut graph is because you can see it. Our purple aspects of the donut graph, 41% are represent Black African American HIV incidents in the year 2019. The green is Hispanic and Latino populations at 29%, 25% white, and then you see how the other groups are broken down as well. And so again, sort of the disproportionate impact of HIV in these communities and sort of what is driving that. And so again, thinking about our discussion about social determinants of health and the role that they play in these communities. Next slide. This is by age. I think important to note here, just briefly, so our purple line graph is those who are 13 to 24 years old. We've seen some decreases in HIV incidence, which is great, but we're also very concerned about that gold line, which goes up and more than doubles. That's our 25 to 34-year-olds. So in looking at this data for the years 2010 to 2019, what I've said to our federal partners is we can't take this in isolation. Our 13 to 24-year-olds are still experiencing high rates of STIs, sexually transmitted infections. So while they may not be getting HIV, we still have high rates of chlamydia, gonorrhea, syphilis in this group. So they're engaging in behaviors that put them at risk for HIV. So we cannot take our eye off the ball with that. Also, this 25 to 34-year-old group, some of them also may be, so that group is our young adults. And what I've said to my federal partners is this presents a little bit of a challenge for us because while we have done a lot of work and a lot of focus on the 13 to 24, trying to reach them in youth groups and trying to reach them, in high school and secondary and college and university settings, when you're 24 to 30, 25 to 34 years old, you begin to live, play, work, and worship a little bit differently. You've got a little bit of more disposable income. You are hopefully off mom and dad's tab, and you are beginning to live your own life, have your own disposable income. You're vacationing a little bit differently, all the rest of that. So what does this mean for our HIV prevention efforts and how we target these groups and where we're reaching them? So getting our federal partners to think a little bit differently based on the data, based on age. Next slide. So the Ending the HIV Epidemic initiative is an initiative that the administration has embraced. It started under the previous administration, but now we're taking it and also revamping our thinking and approach to it. What it does is it focuses the effort on the 48 counties, including Washington, D.C. and San Juan, Puerto Rico, that account for more than 50% of the new HIV diagnosis in 2016. It also focuses on the 7 states with a substantial HIV diagnosis, but are in rural areas. So the dots on the map represent the counties that I spoke about. And the blue shaded states are those 7 states with substantial HIV diagnosis in rural areas. Again, we're calling for a 75% reduction in new transmissions by the year 2025 and at least a 90% reduction by the year 2030. And that gets us to that 3,000 or less that I showed you earlier on one of the slides. Although this is a presidential initiative, it is being led by the U.S. Department of Health and Human Services and represented by the agency's logos that are on the screen in front of us. In talking about this, the rest of the country that is not getting this additional attention and additional focus in both resources and community engagement, the rest of them are still receiving HIV dollars to do this work, both prevention, care, and treatment. And what I've said to them is, you guys are doing a lot of things right because you're not contributing to greater than 50% of the new diagnoses in the United States. So we need you to continue to be innovative and continue to work and keep your epidemics under control. Because if you go haywire, then we're still not going to reach our 2030 goal. So the entire nation is involved in trying to end the HIV epidemic. But as an equity intervention, we're focusing our attention on the areas of the country that have this disproportionate impact that we'll talk about more. Next slide. This slide, I have always loved it. And our dear friend, Dr. Fauci, is the one who sort of talked about this. And this slide comes out of NIH. And what it really says is that we have everything we need in terms of tools to end the HIV epidemic right now, today. From our prevention toolbox, the things that we have online, and even as late as I think last month, new injectable forms of HIV prevention medication, where someone can get an injection and be HIV free from HIV for about 30 days. We're also working on 90 days. So we have new tools coming in to play on the prevention toolbox. Then on the treatment side, we've also got new and great tools that are coming on board. And I'm sure you all have seen the commercials, if you watch television at all, about some of the new HIV medications that are available and that include injectables. So lots on the forefront. Our challenge is access. and also ensuring that there is equitable access. And this is where the social determinants of health come in. Because what we know is that if you're homeless and living with HIV, then trying to meet your immediate need and then talking to you about clinical care and medication adherence is needed. And so how do we design our programs to meet individuals where they are in sort of their prevention and care needs, but also address some of those more immediate needs and the drivers of health so that we can have better outcomes? Next slide. So let's talk about the National HIV/AIDS strategy now that I've sort of set the tone for HIV in general. And also, one of the things that was also a pledge of President Biden's, which was to have a new national HIV/AIDS strategy. So in starting the Office of National AIDS Policy back in June 7th, to be correct, one of my first tasks was to try to get this strategy as a framework for the nation for how we will approach ending the HIV epidemic by the year 2030. Next slide. So we already had the Ending the HIV Epidemic initiative and trying to align those two things, because one of the things we didn't do well was consider the Ending the HIV Epidemic initiative as an equity intervention. So addressing the needs in those areas of the country that have been disproportionately impacted. And so how do we fold that into the strategy and have the strategy be this broader overarching national plan that also extends across many federal departments and the whole nation can get behind it? And so a lot of that work very aggressively took place over the last 6 months, and the new strategy was released on World AIDS Day, as a matter of fact. So next slide. So in doing this, and the alignment, it was great. As I said, it's great to be part of the Executive Office of the President and be able to engage other departments in this effort, because to address the social determinants of health, we need more than the Department of Health and Human Services involved in this HIV effort. And so some of those conversations have been easier coming from the White House rather than being at HHS and trying to engage with agriculture or labor in a very different way. They tend to pick up the phone or respond to emails when you're calling from the Executive Office of the President. Next slide. So the strategy itself builds also on previous HIV strategies that were first developed under the Obama administration, with a vision, our 4 goals, objectives for each goal, and strategies for each objective. The strategy also highlights our priority populations selected based on data, and also talks about our indicators of progress, because otherwise it'd just be a nice, pretty door stopper or window holder open if we didn't have measures that we could use and indicators to measure our progress. So we do have that. And so we, as the federal government, will be holding ourselves accountable. But again, part of this strategy is also to engage all parts of the nation in it. So we will be holding the entire nation accountable for lack of progress, should that be the case. Next slide. So this vision, a couple of things it does that I think are very different, in that it is a vision that looks toward a more equitable approach to the HIV epidemic. It is an inclusive vision that reflects the themes and the aims of the Biden-Harris administration. And it is a vision that sets forth a future where HIV diagnoses are rare, and the people living with HIV are able to achieve their full potential for health and well-being across the lifespan. And so very early in the document, we try to set this tone that then sort of translates into the goals, strategies, and objectives. Next slide. So our priority populations based on HIV incidence, diagnosis, and viral suppression data are all right here. And also, as I started the presentation and talked about and walked through some of the data, and you were able to see some of the progress or the lack of progress among certain groups, This is also part of that decision making that was done. The strategy itself was developed with input not only from the community, but also input from various federal partners across government in making decisions about priority populations and the goals and objectives that were necessary in order to have better health outcomes for these priority populations. Next slide. Goal 1, 2, 3, and 4 are here on the slide. All of our goals are also measurable, and it was really important that as we selected indicators that we also ensured they were able to tie back to the goals and that we were able to measure sort of implementation as we move forward. Next slide. So again, I talked about EHE, but these strategies for EHE are also important components of the national HIV strategy, as well as the EHE initiative. So diagnosing all people with HIV as early as possible. Ways to scale up the availability and access to HIV testing. One of the things we've seen during COVID is a greater usage of HIV self-testing. So home HIV testing has been made available and incorporated. It's been used in a lot of different countries. Previously, in the United States, we were very slow on the uptake, but COVID made HIV self-testing a necessity, especially during the early days of the COVID pandemic, where social isolating was a thing. Many of our public health workers were also deployed to sort of COVID testing. And so HIV testing, self-testing became one way to work toward diagnosing all people as early as possible. I'd also say, engaging in HIV in the community setting, HIV testing in the community setting is also another strategy being used to help diagnose people as early as possible. CDC recommends that all people aged 13 and above receive at least HIV testing once. But if you're sexually active or you're one of the at-risk groups, it's recommended that you get tested at least annually. Treating people with HIV rapidly to reach sustained viral suppression, as I talked about earlier, the importance of treatment and achieving and maintaining viral suppression helps people living with HIV have a long, healthy life. Also, it keeps them from transmitting HIV to their sexual partners. Treatment sounds easy. It is often not. Many people are challenged with taking a daily multivitamin. Same thing with taking HIV medication. Life tends to get in the way. And for many of our priority populations, they have very complicated lives and circumstances that get in the way of treatment. And so I'll talk about those and how that relates to the social determinants of health in a little bit. HIV prevention, we have tremendous tools to prevent HIV transmission, but again, scaling up access, availability, and awareness. Many women don't know PrEP can be taken by them to protect them from HIV transmission. And also syringe services programs, which are part of harm reduction, have been under attack in many communities due to a misunderstanding and misinformation about what harm reduction programs are. It's not just someone handing out syringes and wishing individuals good luck. Harm reduction programs are really connections to care prevention that not only include care and prevention for infectious disease, but also substance use disorder. And so these programs, and we're very concerned, and as I pointed out earlier, this is a group that their new diagnoses are going in the wrong direction. They're increasing. And so trying to ensure that there's accurate information about the role of harm reduction is a key part of our strategy. And then the respond pillar, which is using molecular surveillance to respond to outbreaks of HIV in communities and make sure that there is the availability of prevention and care services within those communities, is one of the pillars and one of the ways we're moving toward the end of the epidemic. Next slide. So in developing the national strategy, there are a couple of things that make this different and unique, and I'll just point out a few of them that are on this slide that sort of pertain to where we're going and what we're going to talk about as also in this presentation. This strategy recognizes racism as a serious public health threat and talks about the ways that racism, structural and systemic racism, drive disparities and affects our HIV outcomes and affects those priority populations that we talked about as well. Underscoring the vital importance of the Affordable Care Act and how it plays in our HIV response, and also paying attention to the growing population of people with HIV who are aging. Many of that 1.2 million are over 50. On one hand, it's a really great thing that now people living with HIV are living long, healthy lives. But as they age, we are seeing coexisting conditions and thinking about specialty care and aging services that one might need as one ages with HIV. So this is sort of the Star Trek new frontier for us in the world of HIV as we look at both what the research says, the implementation, and we also listen to our community partners about the needs that they are experiencing as they age with HIV. Also, this relates to some of this, but quality of life for people living with HIV as well. And we continue our focus on populations in the areas of the country disproportionately impacted. Next slide. So the other thing that I will talk about is how one of the things we've done in the HIV community, and we need to do more of it, is engaging those with lived experience to help inform our federal response, whether it be in research, planning, delivery, assessment, and the improvement of our services overall. And so looking for new and different ways of doing this, COVID has also facilitated made us sort of shift some of this to a virtual world and looking at new and innovative ways to use technology to engage people with lived experiences as well. The other thing that the strategy does is weaves HIV research more broadly into the strategy. Both research for a cure and a vaccine for HIV is still part of the ongoing work to end the HIV epidemic. Most recently, they're starting human trials for some of the HIV work, and so it looks promising, and we are still including that as part of our approach. Next slide. So also some of the exciting work that we're doing is looking at repeal or reform of state HIV criminalization laws. Many of these laws are on the books. They are not necessarily tied to transmission. They are laws that are contributing to the stigma and discrimination surrounding HIV and getting in the way of our national goals. So we are working both with advocates on the ground to figure out what else the federal government can do to support them. We're also working across the CDC as well as the Department of Justice on looking at ways to support state efforts to reform these laws as part of the plan as well. The other thing, two other things I'll point out on this slide, opportunities to engage the private sector in new and important ways. Private sector can do a lot of things differently, sometimes even faster than the federal government. With a lot of the mistrust in government we have right now, private sector in many cases is a great partner because they have the community entree and access to different populations where the federal government may be struggling. So we are engaging different sectors, not just pharma, as often folks think with HIV, but also our commercial sector. Many commercial partners are involved in trying to end the HIV epidemic. And we're thinking about and beginning to have conversations with the tech sector. And then and also looking at ways to work with communications and marketing firms around some of these pieces as well. And then expanding our focus on addressing the social determinants of health. So next slide. So to do all of that, we really couldn't just rely on HHS. A lot of the programs that influence the social determinants of health rest in other departments. So we're thinking about SNAP and WIC and food insecurity. Then we need some of these other partners at the table. But we're thinking about ways to influence education and provide not only what happens in the educational setting, but also ways to provide educational opportunities that may lift individuals out of poverty and lift them out of HIV risk then we need the Department of Education at the table. When we're thinking about these issues of HIV criminalization, or we're thinking about the incarcerated populations and the role prison and jails play in HIV, we need the Department of Justice at the table. Employment opportunities and helping individuals learn trades or go back to work or back to work programs. It's the Department of Labor. So our HHS partners have done tremendous amount of work and still do when it comes to HIV. And then one of the things we've been excited about is we've always had the housing opportunities for persons with AIDS program, and they've been a great partner throughout all of this and working with us. But now through this new strategy, we've got other parts of HUD to the table and having conversations about ways to increase HIV awareness in other HUD programs, HIV connection to HIV testing, and thinking about how they might do some of this work as well. And then there's the Department of Veterans Affairs, which has also been previously engaged, along with Indian Health Services. They too have great partners, and they have also systems of care that are working to address some of these issues. The other department that we're also working with is not listed here because we still haven't figured out how exactly they will enter in, is the Department of Interior. When it comes to social determinants of health in tribal and native lands, the Department of Interior has a lot of programs, including the Bureau of Indian Education and the Bureau of Indian Affairs, which deals with jobs and housing and roads. And so they do a lot. And for the first time, we're engaging them in our HIV work. And we have a meeting set up in the next couple of weeks to talk about what that could look like and the fact that we need them in order to be successful and address the social determinants of health among the Native community. Next slide. So let's do this. Social determinants of health and HIV. So I've set all of that up, and now let's dive into it because I've got a few minutes and we're still going to leave time for questions. Next slide. So the social determinants and their impact on health, and here's where we sort of see this. And this goes to my point on the last slide, where the health behaviors down at the bottom of the pie chart are about 30% and have sort of this influence here, along with, which is greater than clinical care or physical environment and genes and biology. But the social and economic factors are at 40%. So if we don't try to influence those determinants of health in a different way, then we won't get the outcomes we've been investing in trying to get for the American public. And the quote here that I included on this slide is sort of, I think there's been a great conversation about the role of social determinants of health. And we've all seen it sort of like through the COVID-19 pandemic. It was almost like one of those injectable dyes that you get at the hospital where it sort of shows all of our weaknesses and flaws within this system of health and public health that we've been working on and creating. And we were able to sort of see, and many of us, including many African Americans, knew this was going to be bad and that this was going to have an impact. And yesterday, I talked about the fact that even in my own family, we were having conversations about its impact. And even though the family knows what I do and all, what I was also doing was remarking on how some of these social determinants were impacting us and the decisions about how to protect ourselves, our ability to protect ourselves and isolate through COVID-19. And I think it was for the first time they got, like many Americans, a real understanding of public health and its issues and the social determinants. Next slide. So as we talk about social determinants or the social drivers of health, we're talking about our neighborhoods and our built environments, housing, transportation, safety, home modifications, food and nutrition, education, community and social contacts, our financial stability, but employment and income. And when I talk about sort of how this sort of showed up in COVID-19 as an example, I think we all can relate to. There were conversations in the family about my sister's husband who drives a bus in Chicago. How is he gonna socially isolate? And this was also at a time where he couldn't necessarily take off work because my sister, bright as she is, decided she was going to give up work and go into nursing school. That also had its own set of perils during COVID-19. And so how all of this played out in some of the family discussions. And then when my brother-in-law, his brother, got COVID symptoms and went to a hospital, and my sister and I having a conversation, this was in June or July of all of this in 2020, about why did he go to that hospital? And that hospital saw his shortness of breath, some of the other conditions, and they sent him home and said he had walking pneumonia. My sister, who's in nursing school, me, I'm saying, no, that sounds like COVID symptoms. He shouldn't go to that hospital. He should go on the north side of Chicago. He needs to go to Northwestern, have them see him. And she says, I'm going to try to convince him, but he hates hospitals. He took what they said and just walked away. This was a Saturday. By that Monday morning, he had passed away to COVID. All of that conversation about race and job security and the fact that he was a security guard also and didn't want to necessarily be off from work, poor quality care at an under-resourced hospital, the conversation about, no, he should go to the north side and go to the white hospital and get better care and treatment. All of that is wrapped into social determinants of health. And I think there were many, many conversations as a result of COVID that came to the forefront. And there are many things that from the HIV community we saw, we learned, we knew. And I think in HIV, we've done a better job in 40 years of collecting the kind of data to be able to understand health disparities a little bit better and address social determinants of health. Next slide. So it was also great that equity is at the center of many of the initiatives of the administration. And so there is this drive to address there's a desire to address the drivers of health and recognize that it is going to have to change how and what we measure in healthcare. The Commonwealth Fund talks about the drivers of health that account for 80% of the health outcomes and have this disproportionate impact on communities of color, and what these all encompass. And a lot of these we've known in the HIV field, which is why I think on some level, we're a little bit ahead because we've been collecting data on these groups and also looking at the interplay of these drivers of health as well. And in some examples, trying to address them. Next slide. So what we know in HIV is that with adults with diagnosed HIV, 61% had sustained viral suppression, 39% did not. 43% had disabilities, 41% were unemployed. 42% had household incomes at or below the federal poverty level, and what this looks like and how this shakes out. And then the other things that sort of come along with it, like depression or anxiety, the use of drugs for non-medical purposes as well. And so we've collected a lot of this, and some of this comes through what we call the Medical Monitoring Project, which is done by the Centers for Disease Control. Next slide. And that gives just a little snapshot. When it comes to housing instability and food insecurity among people with HIV, using the Medical Monitoring Project, again, you can see some of this. 9% were homeless. 13% had moved in with other people as a result of financial problems, so they are unstably housed. 3% had been evicted from housing, and 10% have moved 2 or more times in the last year. So again, here we have food insecurity, many of them having access to SNAP or WIC, transportation assistance, medical food. So a lot of sort of the interplay of the social determinants of health among people with HIV, and also when we think of those who are at risk, those who might exchange sex for food, housing, or money, or in a situation where violence is present. So again, how these drivers of health interplay and the data that we've been able to collect have really helped us in thinking about this differently. Next slide. Again, sort of looking at HIV and COVID and the disproportionate impact of communities of color, sort of not sitting back, but sitting at home and watching some of this, continuing to try to do HIV work at the same time of COVID-19, and the realization of the communities that we were trying to reach were being disproportionately impacted by both diseases. And so, and many of our public health workers, those involved in HIV, had been deployed to COVID to address the needs in their communities or the needs in their public health department in order to continue to do some of this work. But again, it was that intersection, particularly among communities of color. Next slide. So Greg Moulette at AMFAR did some definite research during this time and published this in the Journal of the International AIDS Society, sort of looking at some of these issues. And what he found was that what was common here was the way the pathogen was working within communities of color, and that race being one of those key factors, and the need to look at the disparities and to look at the drivers of health and to understand how structural racism was in play, and using the pathways of the social drivers of health to exacerbate some of these disparities. Next slide. So as a result of all this, there has been this outcry, not only from NIH, but CDC, and also some of the write-ups in editorials about racism as a public health issue and racism as a public health threat. And it's because of the way racism uses the pathways of the social drivers of health to create these disproportionate health impacts in communities of color. Next slide. So before you get completely discouraged and think, oh my God, Harold, are we going to try to end racism? We may not end racism in the time that I have left on the planet, but I think that we can influence the drivers of health and work toward the end of the HIV epidemic and other disproportionately impacted disease specialties and states as a result. Next slide. Here's a lot, and I'm going to leave this with you, a lot of the executive orders already that the Biden administration has put forward since last year on addressing the social determinants of health. I think there's one more slide filled with them, and I can't take credit for collecting all of these. Someone else did that. Next slide. Yeah, and there's also current funding supporting social determinants of health through the American Rescue Plan that are also touching on different departments. And I think, as you can see from this, some of those also are outside of the Department of Health and Human Services. So working with those other programs and those other partners and getting them to understand how they drive health outcomes. Next slide. And then just one more set of SDOH initiatives from the administration. And the last one that I will put on, the last one I will put on here is the Social Determinants of Health on the Congressional Caucus, where they're looking at opportunities to improve the impact of services delivered to address SDOHs with federal funds. So that congressional piece is going on the legislative front, but most of these have come out of both the administration working hand in hand with Congress. Next slide. So when I talk about sort of our progress in addressing social determinants of health, the Ryan White program is a great example of this. It's a program that not only provides HIV primary medical care to those who are uninsured or underinsured, and also medications, but it also provides support services. And those support services, excuse me, that are allowable under the program are also for those who are HIV positive. The program serves over 500,000 people with diagnosed HIV in the United States. And because it is for those who are uninsured and underinsured, it's the payer of last resort. So it works in collaboration with other programs. And what I used to say is that if there's another way to take care of your needs, that program gets used first. And then Ryan White sort of wraps around and supports some of those other pieces. Excuse me. So with the program seeing over 500,000 people, 89% were virally suppressed in 2020. Which exceeds our national average. And yesterday, as part of National Black HIV/AIDS Awareness Month, they also announced that African Americans in the Ryan White program have reached overall an 86% viral suppression rate. So they have closed the disparity gap when it comes to the Ryan White program for African Americans. I remember maybe it was 10 years ago or so, it was about in the 60s. So, but again, focusing, using the data, and I'll talk about how we can drive outcomes in a different way, much like the Ryan White program did. But it is part of their key is the wraparound comprehensive service model in assessing the needs of clients. Next slide. Got a few more examples. Positive Impact Centers had been working on a program that looks at the intersection of housing, healthcare, and social work. And again, it's understanding where clients come into the system and what some of the needs are, and developing a plan to help them address some of those other needs for support, whether it's housing or whether it's income, and working toward that goal while focusing on their medical care as well and those health outcomes. Next slide. Again, similar program, Homeless to House, where they're looking at patients who get referred into the program, how the patients are actively engaged in the development of a service plan that meets their needs, how they begin these additional services and the types of services that are available to them, and then working to be able to do this. This was part of the HIV Housing and Employment Program project. Boston University excuse me, was involved with the HRSA's HIV/AIDS Bureau in pulling all this together and really thinking about the intersection of those social determinants of health and how they impact health outcomes. Yes, thank you. Next slide. Another one that I just learned about, and I got permission to talk about this, AIDS Healthcare Foundation in Los Angeles has a new program called Food for Health. And Food for Health, their goal is to provide sustainable solutions to food insecurity for their clients. What they've done, especially during this time, is work with local farms and growers in the Los Angeles area to stock their food pantry and food boxes with farm fresh produce for clients. And this was important, I think, both from an economic standpoint for the farms who were struggling because restaurants were closed during COVID in Los Angeles. But here was a driver of health and that needed to be addressed. And so they formed new partnerships and this new collaboration, which is helping their clients. And so they're right now piloting this. They want to look at the health outcomes as well, but as sort of trying something new to try and address the issue of food insecurity, which drives health as well, is something that they're working on. Next slide. So with some of those examples of how we can drive health, one of the things and lessons we've learned when it comes to HIV is being able to use the convening power of public health, but not expecting public health to do it all. Because like I said, we need those programs out of HHS that to be partners and collaborate with us. Finding partners with similar goals and missions to improve individual, community, and population drivers of health. Working with whether it be the private sector or with some of our other public programs that are available at the state and local level, looking for that intersection and being able to address that intersectionality. Being able to look at the data by race, ethnicity, sexual orientation, gender identity is also important. And also being able to drill down and look at the differences in different parts of the country, either by ward or precinct, county, state, and region. Like I talked about the Ending the HIV Epidemic initiative, which is a county-based initiative that also includes those 7 rural states. And one of the keys to the success of the Ryan White program was their ability to look at the data by race and ethnicity and by gender and begin to see some disparities almost 10 years ago and think about and ask questions, not only of themselves and their program recipients, but of the community. What's going on here and what's driving it? And then having and developing plans and programs to close that disparity gap. Data collection and the ability and data sharing among programs is really important. When we're talking about trying to share data between programs that are outside of HHS, very often the first red flag people will throw is the idea of data privacy and data protection. But we can't let data privacy become the excuse to continue these health disparities. we have to figure out how to do data sharing agreements between programs that are working in consort to be able to help drive better health outcomes. Developing trust among collaborative partners and understanding the capabilities and the limits. As we have new partnerships and new collaborations, there are some powers and authorities that some of us have that not all of us have. And it's really important that as part of developing that trust, that we have the understanding of what the capabilities are and what the limits are. We have to continue to look at ways to provide the ability to braid funding streams and programs so that they can work together. Here in Washington, we tend to talk about intersectionality, especially recently, but yet we still fund categorically. So that there's programs over in agriculture and there's programs over in health. And so, but on the front line, there's a need for those programs to be able to braid those funding streams to adequately address the needs of the community and the population. And so one of the things that we're thinking about and looking at is how can we eliminate some of those policy barriers that we unintentionally create by doing categorically funding certain initiatives to allow programs to be more flexible and to meet needs of individuals where they are. Also, engaging the target population in the solutions is also important as we look to drive determinants of health, really thinking about the community's priorities and embedding them in our work and aligning those is key to success. Next slide. So just briefly how we're going to measure success. Next slide. Our national strategy does not include action steps. It just includes strategies, objectives, goals. Also, it talks about how we're going to measure our success. The federal agencies are currently in the process of putting together activities that are going to align with the strategies. We're going to do progress reports on that, and we're also going to measure the progress. Next slide. I won't go into detail here because I want to leave a few minutes for questions, but we're also using indicators of our progress, and all of the action items that they submit need to be aligned with how one of the indicators and describe how it's going to move that indicator forward. Next slide. Also, I talked a bit about this, how we're working on quality of life moving forward. It's a developmental indicator. We think it'll have a great impact on how we think about people living with HIV moving forward. Next slide. So again, focusing on our priority populations, again, based on data. So very data-centered and driven plan for moving forward. Next slide. The agencies have the guidance. They have until April 5th to submit those activities to us, and we'll be reviewing them as part of our work here in the White House. Next slide. Again, just ending with our vision for where we want to get to with the HIV epidemic, and the recognition that we must impact the social drivers of health in order to get there and have a more inclusive and equitable response to the HIV epidemic. Next slide. Thank you.